Okay, let's get started. Hello, my name is Alan Hudson from the Immuno-Oncology Translational Network Data Management Resource Center. I also serve as Chair of Biostatistics and Bioinformatics at Roswell Park Comprehensive Cancer Center. Before we start the seminar, I just have a few bookkeeping items to go over. Questions will be responded to at the end of the presentation. Please enter your questions in the Zoom Q&A box, not the chat box. The audience can prioritize the order of the questions by clicking on the thumbs up button. Closed captioning is available. The closed captioning for today's webinar can be accessed clicking on the live transcript option in the Zoom menu at the bottom of your screen. Instructions are also provided in the chat box. If you're having technical issues, you can make a comment in the Zoom chat box. With that, I would like to turn the proceedings over to Ms. Nani K. Shelburne, who is Program Director in the Epidemiology and Genomics Research Program within the Clinical and Translational Epidemiology branch. Ms. Shelburne is an advanced oncology certified nurse and a certified registered nurse practitioner in acute care oncology. Nani K.
Thank you. Welcome, everyone. Today, I will serve as your moderator. The Moonshot Inherited Cancer Syndrome Initiative is a part of the Blue Ribbon Panel's early prevention and detection recommendation. This initiative aims to increase case ascertainment, optimize the delivery of evidence-based follow-up healthcare, and enhance our effective communication and decision-making for these individuals we determine to be high risk of cancer due to an inherited genetic susceptibility. Today's speaker has a funded study within this initiative that's focused on Lynch syndrome screening, and I'm very delighted to introduce Dr. Alanna Rahm and have her here to share her work. Dr. Rahm is an associate professor in the Genomics Medicine Institute at Geisinger, where she leads efforts in the implementation of precision health and genomics programs within healthcare system, and where she co-founded and co-directs the dissemination and implementation community at Geisinger. She spent her research career in integrated health systems, where she's committed to fostering and building learning health system environments to support the continuous collaboration of research and practice. She is a certified and licensed genetic counselor and has a doctorate in health and behavioral sciences. Dr. Rahm is also a board member for the Lynch Syndrome Screening Network, which is committed to promoting universal tumor screening for all individuals with newly diagnosed colorectal and endometrial cancers, with the goal to reduce the cancer burden associated with Lynch in patients and family members. Today, she joins us as the principal investigator of the Moonshot funded project on implementing universal Lynch syndrome screening across multiple healthcare settings. Thank you for joining us today. I'll hand it over to you, Dr. Rahm.
Thank you so much, Nani K. I just want to confirm that you can see my slides. Okay, super. All right, thank you all. Thank you, Nani K. Thank you, everyone. Thank you so much for having me here today. I'm really excited to talk to you about our project, again, which is focused on improving the implementation of genetic testing for Lynch syndrome through implementation of universal tumor screening programs for Lynch syndrome. So I do want to level set and first let everyone know what is Lynch syndrome, why do we need to be concerned about that? So just as background for those who may not know, Lynch syndrome is is a hereditary cancer syndrome. It is the most common hereditary colon cancer syndrome. With it comes up to 75% lifetime risk for colon cancer, often presenting at earlier age than typical population screening would pick up, and therefore they're also diagnosed at later stages as well. It represents about 2 to 5% of all colon cancers, and women also have a 30 to 60% lifetime risk of endometrial cancer. And about half the time, women actually present first with an endometrial cancer. So that's, again, where it's important to identify individuals with Lynch syndrome, because, again, it affords the opportunity to prevent then future colon cancers or catch them earlier if we know the individual has Lynch syndrome. It's also important for their family members, because siblings and children of someone with Lynch syndrome, so those first-degree relatives, have a 50% chance of also having Lynch syndrome. And if we know that they have Lynch syndrome, again, they can start to take advantage of prevention and screening opportunities that maybe normally they wouldn't do based on population screening guidelines. Because right now the estimates are that fewer than 2% of individuals with Lynch syndrome in the United States are actually know that they have it. So over 95% remain undiagnosed at this point. It's also considered a CDC Tier 1 condition, meaning that there is strong evidence that identification can help reduce cancer morbidity and mortality. And one way to facilitate the identification of individuals with Lynch syndrome is through what we call universal tumor screening programs, or universal screening programs of all colorectal and endometrial tumors, or individuals with cancer, colorectal cancer and endometrial cancer, through these universal screening programs. And that's been recommended since 2009, when the EGAP recommendation first came out. So again, but this is a complicated process, particularly for these tumor screening programs. Originally, when they came out back when we had to be concerned about testing costs, we would could identify using immunohistochemistry which gene might be best suited to be tested for first. So there's multiple pathways to get through this process. You can see it's multi-step. It can involve multiple departments within a healthcare system. So usually this testing here, the tumor testing is done by pathology. Results have to go back to oncology. Oncology has to refer to genetics, and then the patients have to get to genetics. So it's complicated. It's a multi-step process. So this may be part of the reason why it's variably implemented across healthcare systems, even though the recommendation has been out since 2009, and still most people with Lynch syndrome remain undiagnosed. And so again, so that we really want to try to identify them so we can do prevention and early treatment, things like that. The opportunity came about again in 2016. This little thing called the Cancer Moonshot came out in the Blue Ribbon Panel Report. And within the Blue Ribbon Panel Report, specifically the Precision Prevention and Early Detection Working Group came up with recommendations for 2 demonstration projects, specifically calling for a recommendation for Lynch syndrome screening, and particularly around the identification of all colorectal and endometrial cancer patients with Lynch syndrome, and the identification of family members at risk for Lynch syndrome as well, as a major goal, really recognizing the importance of improving our identification of individuals and genetic testing of individuals with Lynch syndrome through these programs. So that was our opportunity to really dig in and study this. The tools we wanted to use to study this are the tools from implementation science, which is a whole nother talk in and of itself, but this is just the lens and the tools we used for this study. And the reason we needed to do this was because implementation science really gives us helps us understand and illuminate what works for who, when, and under what conditions, and in what context. So in this case, we could use the tools from implementation science to look across different healthcare settings and systems with varying degrees of program implementation, different contexts, different system types, different patient populations, different resources, and help us understand what is happening when systems consider implementing or decide not to implement these programs, and what are those difference makers that we can identify between those that make the difference in those different settings and different contexts. So the Impulse study was created to understand this variability in tumor screening implementation for Lynch syndrome, and to utilize it to better guide our program implementation in any setting. So we wanted to utilize the conceptual, basically the tools from implementation science, specifically the CFIR, or conceptual framework, consolidated framework, excuse me, for implementation research, which I'll talk about in a minute, to help describe, explain, and compare those decision-making issues and factors across our multiple healthcare systems, but really to be able to make that accessible and usable by any healthcare system trying to make these decisions by creating it or turning it into some sort of organizational level toolkit. And we also hoped that will also become a use case for understanding and implementing other genomic medicine programs in the future. So to do this type of a project, we of course needed multiple healthcare systems. And so as part of the Healthcare System Research Network and the wonderful group of collaborators there, we were able to pull together a number of healthcare systems where we could do this work. And again, the Healthcare System Research Network has been around for over 20 years, an environment that many of our healthcare systems participate in. And so we were able to identify a number of healthcare systems that we could work with across the Healthcare System Research Network. We also included, you can see here, they're across the country, various locations across the country. And then we also have a couple of non-HCSRN sites. And that was important because that gives us not only a different representation of service types. So some are fully integrated healthcare systems. You have to be a member to receive care there. Others are open systems, and we have fee for service as well. But they also all have different levels of implementation of Lynch syndrome screening programs, particularly tumor screening programs. Some are just doing colorectal cancer, some are doing all colorectal and endometrial cancers, and some did not have programs at the time. And so that was really important to have that variability to understand what's going on. And when we say they have no program, it doesn't mean that they don't do genetic testing for Lynch syndrome. What it means is that they don't have a systematic program to ensure that they've tried to implement to ensure that they are screening all colorectal and endometrial cancer patients for Lynch syndrome and facilitating the genetic testing of those individuals for Lynch syndrome. When we say a site had no program or a healthcare system doesn't have a program, it just means they may have ad hoc or other way, basically provider initiated referral to genetics, but no systematic program in place. And so again, this gave us because of the need to uncover pretty much what we don't know, the complexities of what's happening in these already complex systems and very different systems. We relied very heavily on qualitative data collection. So you can see here, we really collected a number of stakeholders from all of our sites, including organizational stakeholders, clinicians, patients with Lynch syndrome, to make sure that we could understand what was going on here. And we did this using or guided by the Consolidated Framework for Implementation Research. And the reason we did that is because it guides us to focus on not only the system itself or the inner setting, the individuals involved in that setting, so the clinicians, the patients, but also what's going on outside of the system, the outer setting, the policies, the external environment with which the system is located, as well as issues with the intervention itself or the tumor screening programs and how it fits when it's not adapted versus how the systems have to adapt them to make it work, as well as all of the processes that may be changing over time. And the CFR guide provides really, it has interview guides. It's very comprehensive. Within these domains are constructs that help us really set out and look at all of those different things to help us understand what may be contributing or not to these differences between those sites that can implement and those sites that can't or haven't yet. And so we were doing that through a cross-case analysis as our first step. So we utilized the CFER to create our interview guide, to code our multiple organizational stakeholder interviews. So we used it as our code book as well, as our data collection tool. And this worked regardless of whether this system had implemented a systematic program or not. And then what we started doing, now that we had all of those interviews, and this was a large amount of data, we started looking at preliminary data that was presented by one of our team members, a genetic counselor at the National Society of Genetic Counselor meeting, where we were able to start seeing that if you take a system with a program and a system that had not implemented a program, you can really see there are, yes, things that are similar between the systems. So these are maybe things that aren't difference makers, but we can also see things that might be making a difference, or things that are similar but may be a barrier in one system and a facilitator in another. So we could start adding valence to these things and seeing how they were impacting the programs. And so this is the start of this cross-case analysis, and it really did illuminate that our healthcare systems are super complex, right? But also that we could start to see patterns and commonalities and things that might potentially be those difference makers. We can also start to see that stakeholders required might be different at different stages of implementation, which was really critical. The other thing we started doing seeing within this analysis, so we conducted 65 interviews over our 9 healthcare systems, which is actually a very large number of interviews for qualitative work that results in huge amounts of data. But it resulted in 19 analytic units for our healthcare systems. So while for some of you who work in healthcare systems, it's maybe intuitive that there are different units within your healthcare system. So your healthcare system may not be one full system. It may be multiple units within a system, and those units may be very distinct and different. So we did have some healthcare systems that we could analyze as one system, but others were multiple analytic units, 3, 5 analytic units within a healthcare system. And these different analytic units within one healthcare system, one analytic unit might have implemented a program and one might not have implemented a program. So it really depended on what those systems look like. And doing this analysis this way allowed us to really do that separation and to show based on what was going on within that analytic unit and compare them against each other. And to show, again, within a healthcare system, what you might have to do if you have multiple units within your healthcare system. You may need to do different things to implement these programs within your system. There would not be a one-size-fits-all. So after we got our 19 analytic units, we also, the next step in our process to understanding and improving the implementation of these programs and understand what's going on is to use a methodology called qualitative comparative methods. Specifically, we're using a configurational comparative method called coincidence analysis. And the main goal of coincidence analysis is to identify essentially causal chains of conditions that are minimally sufficient and necessary for our implementation outcomes that we were looking at. So that would be the difference between whether a system can implement a program of any type or not, or they choose not to implement. And in systems that have programs, how optimally functioning those programs are, and the differences between optimally and not optimally functioning programs. And so coincidence analysis is this, it's a methodology, an analytic methodology that's really gaining popularity in implementation science because of the way it helps us really identify those contextual conditions. You think about it, our lead project lead on this, Debbie Cragen from University of South Florida, describes it as, you think about chocolate chip cookies, right? There are many different ways to make chocolate chip cookies. So some of those things don't make the difference. But if you put in raisins instead of chocolate chips, now you have a raisin cookie and not a chocolate chip cookie, right? So those are things that make a difference, but they both may have flour in them. So coincidence analysis allows us to take all of our qualitative data and do that and really identify those difference makers. So one of the first things we had to do to understand this is we created process flows for the tumor screening programs in each of our analytic units. And what this did is we could notice then areas of disconnect and uncertainty within the process. And so on the right here, you've got a system that is more optimized. They've had a program, it's more optimized. And they still have a few places where they might have breakdowns in the system, but they know that they're there and they have processes in place to deal with them. Whereas the system on the left here is one where there's a lot more process breakdowns or decisions that they don't know how to implement within that process of the process flow, so to speak. So this is the first step to identifying where are those breakdowns in our analytic units and what might be differences between optimized and not optimized or implemented and non-implemented programs. Then we can take those factors identified from our interviews, using those CFR constructs that we hypothesized to make a difference for the outcome within each of those domains. So the outer setting, the characteristics of the program, characteristics of individuals, the inner setting, and the process. And start to see what are the different difference makers again. So we coded for all of these within our data. And then we were able to create a score, an implementation and optimization score. So for here, across all of the different analytic units, we could turn it into we actually used a 5-point optimization scale and a 3-point implementation scale. So again, the implementation was split into whether they had an optimized program, a program of some sort, or they had basically an ad hoc program. So that would be the optimized program, the program of some sort. They're trying to do something to systematically identify all individuals. And this would be, they're still just doing ad hoc genetic testing. And so that was our implementation and optimization score. And then we could compare it, create a data matrix essentially across the coding, across all of our CFR constructs and domains, where we calibrated them for the factor values. So whether they were mostly positive, so everything within that factor was positive, or mixed, meaning some people were positive and some people were negative, or had noted facilitators and barriers. And then to another valence of whether it was fully negative or mostly barriers presented. And you can start to see, when we do it this way, you can start to see that there are some differences between, as you go from the optimized and implemented programs to those that have done something, but haven't got it fully optimized yet, and those that still have decided not to do any systematic screening yet. And then we use the coincidence analysis. What that does is it turns it into our solutions for implementation and optimization. And so our preliminary work, our preliminary solutions right now that we're using to create our toolkits and are in preparation are, so for programs that are fully optimized and implemented, really the key difference maker seems to be a maintenance champion, as well as positive inner setting factors. So meaning people within the inner setting, people feel confident about it. They agree that it's necessary to be doing this testing. All of those things are positive for all stakeholders. for sites that, or analytic units that have programs, have started doing some systematic screening and testing, but may not be fully optimized. We're noticing there's some difference makers, particularly around they have to have the positive perceptions of the relative advantage of having a screening program, and believe the evidence and positive feelings towards the evidence for doing that. But they may have other mixed feelings about it. So they may have both facilitators and barriers that keep them from being able to fully implement a program. Or they may have all of those things, but they may not have a maintenance champion, because a maintenance champion can be somebody different from, as we noticed in our data, it may be a different person or champion than the person who actually gets the program up and going. But either one of those can lead to, processes can lead to a non-optimized program. And then leading to the factors that seem to be leading to choosing not to implement any sort of systematic Lynch syndrome screening of our colorectal and endometrial cancer patients starts with mixed perceptions, makes sense, or full on not believing the evidence, or I don't want to say not believing, but negative attitudes or lack of knowledge that of the guidelines. And that can lead to an absence of planning and engagement among stakeholders, because there's no reason to do that. And so that seems to be what's leading to the choice not to implement a program at this time. And so these are those things that we can use that then tell us how to create, how to optimize this process, and how to help healthcare systems get over those barriers and actually implement programs, how to help our champions, and how to facilitate this through the creation of a toolkit. So we use this information to start creating our toolkit. And our toolkit actually focuses on 3 different processes. So first, there's the process of deciding to implement at an organization level. So making the case for universal tumor screening for Lynch syndrome and the genetic testing. And so that toolkit for making the case, because of what we learned through the coincidence analysis, really focuses on the relative advantages and evidence for creating a universal tumor screening program and ways to successfully engage your stakeholders within the system. Whereas then for, if you're past that process, or for sites that need that step-by-step planning guide, how do I actually implement step-by-step? We include, then go into the step-by-step guide, ways to improve all of those factors within the inner setting that seem to be important across our different systems, as well as talking about how the importance of a maintenance champion and how to identify that, as well as how to track and maintain your information over time so that you can maintain an optimized program. And then, because we notice that some programs are also, they may be optimally functioning, or they may know they need to optimize and try to figure out how to do that. But even optimized programs are questioning, when do I change? When do I evolve? And so we have another one that focuses on existing programs, the evaluation and improvement of existing programs. And that focuses on that ways to improve the inner setting factors that you can identify that maybe those barriers for your system or unique to your system, but how to improve those. And then again, focusing on the importance of a maintenance champion and tracking and reflecting, the reflecting being important for when you change a program. The other piece I need to address in this is cost. So an important consideration in both our toolkit and within the implementation of these programs is cost. There's different protocols that are recommended and have been for years, and genetic testing costs are decreasing. They have been for the past decade, right? And new technologies are coming available, and different systems may be resourced differently or have different facilities. They may have external pathology. They may have internal pathology. They may have external genetics. They may have internal genetics. So all of that plays into how healthcare systems make decisions about implementing these programs, and that usually, or that sometimes can reduce to this question of cost. So we wanted to make sure we included an analysis and an ability to understand those costs within the toolkit, because this can lead to them placing restrictions on what age limits get tested for or screened for Lynch syndrome, or whether they do just colorectal and endometrial cancer. So we have a health economics team led by Dr. Howe and her team. And what we did is we set out to update the analytic models that were out there. So we first developed our 8 decision analytic models that reflect the currently available approaches, and using our our typical modeling process of hypothetical cohort of 1,000 patients using 2018 dollars. But we also made sure that it was from a healthcare system perspective, which means we also included the costs of getting to genetic testing and the costs of the genetic counseling, the genetic testing, and the number of patients going through that and where they may drop off. And we updated our models for that, which has been recently published, so you can find those. But what we did find, obviously the most sensitive and the highest sensitivity and specificity, pardon me, was in if we just did direct germline sequencing of everybody with colorectal cancer, or tumor sequencing with to germline sequencing. Those identified the highest number of Lynch syndrome patients, highest sensitivity and specificity, but they're also still, in this day and age, the most expensive. So the original protocols, the IHC or the immunohistochemistry first step, which is that one protocol I showed at the beginning, or starting with a molecular test for microsatellite instability, are still the lowest cost, but they're those complex processes that include other tests and that to get to germline testing. So a question a lot of people asked as well, and so we did include this in the analysis, was what do our costs have to be for germline sequencing before it becomes cost equivalent? Because you can see as costs have been coming down, these aren't too far apart. And so we found that there was a cost of $368, which per genetic test, which some of you may already have a cost less than that in your system. That does factor in the cost associated with consenting or genetic counseling and testing, but it also assumes 100% capture, meaning no patient drop off at every step, meaning that 100% of your colorectal cancer patients also went in for genetic testing. So what our health economics team was able to do is they actually transformed this general model into a user-friendly modeling tool that is Excel-based, so that instead of them having to take the numbers from our healthcare systems and run it in the model for the healthcare system, individual decision makers in our healthcare systems can actually get into this tool and play with the numbers and ask these questions like, what do my sequencing costs have to be, to help them make their decisions about their programs. And it provides them the costs per case identified. It gives them total program costs, and as well as allows them to see, well, what if I get all my patients in, or I don't get all of my patients in? How is that impacting my costs? So they can ask all those different questions that we had heard using this tool. And so this is another piece of our toolkit that we have put in there. We are in the process currently of user testing this modeling tool for inclusion in our toolkit. And so now the next step is, of course, dissemination, testing, and improvement of our toolkit. And so our first major route of disseminating our toolkit is through the Lynch syndrome screening network. and this is just a screenshot of our a preliminary opening page of our toolkit. And this is meant to be an interactive toolkit. So you can see we've got the different deciding to implement, planning to implement, that step-by-step process, and improving how to improve programs. So it walks them through those different places as we've learned from our analyses. We're also in process of user testing this, so this is changing. These are not the final toolkit that will be up on the Lynch Syndrome Screening Network website. But we also, I want to just point out that we, from the get-go, it's designing for optimization, because again, we've noticed that sites may be able to implement a program, but unless you think about everything to create an optimally implemented program, you still won't get the individuals to genetic testing. And so we've done that using a sort of a question and response type format. And again, we're in the process of user testing that. We also give them a basic overview of the costs and let them, of the three main processes that we've heard so far that people are considering when implementing these programs or changing their program, and give them, the goal is then to give them access to that cost tool, the user-directed cost, user-friendly cost estimation tool right here through, again, another button click. We also importantly include other information particularly from patients across all of our healthcare systems. So both individuals with colorectal cancer who may or may not have gone through these universal screening programs, as well as the acceptability of testing and screening from individuals who have been identified with Lynch syndrome through these programs. And so that is also a part of the toolkit that we are including. And next steps from there are to then, again, incorporate the modeling tool for the different toolkits into our toolkit. We will be finishing our user testing. We will be disseminating it through the Lynch Syndrome Screening Network and do iterative improvements as we use it over time. We've also been doing some additional stakeholder engagement and strategic planning for the Lynch Syndrome Screening Network and the use of this toolkit and moving forward for Lynch syndrome screening, which we have a small grant through the Eugene Washington award mechanism through PCORI, where we've partnered with the Lynch Syndrome Screening Network, as well as our friends at Alive and Kickin', a patient advocacy organization, where we've held engagement activities at a Living with Lynch patient conference, as well as the Collaborative Group of the Americas conference for researchers and clinicians interested in Lynch syndrome screening as well, so that we can start to figure out the best way to use these tools going forward that will make a difference to individuals with Lynch syndrome, as well as how our stakeholders in our systems may want to use these tools. So because again, this continues to be important, we want to make sure that all individuals are identified. This was a Healthy People 2020 objective. It remains a Healthy People 2030 objective to increase the proportion of people with colorectal cancer who get tested for Lynch syndrome. We hope our toolkit will facilitate this now. Also, the newest Moonshot our cancer panel report that came out also really highlights the need for getting people to genetic testing and counseling for cancer risk assessment. Again, improving the number of individuals with Lynch syndrome that we get into genetic testing so that we can get them identified. Critically important still, because we don't want to be quoting that 95% remain undiagnosed number as we continue forward. I also want to acknowledge the elephant in the room here. I've sort of mentioned it as we talked about the different protocols that can be thought about in these screening programs. Which is what we often get when I talk about implementing these universal tumor screening programs to identify all individuals with colorectal and endometrial cancer with Lynch syndrome for genetic testing. Well, we should, of course, we don't want to wait till they have cancer. We want to identify them before they have cancer. Should we be doing population screening? All of these things are coming up. But again, our healthcare system in the United States is fragmented. People are different. Our clinicians are different. And so really this is one approach of many that when implemented together and when each of these programs is implemented optimally, that's what's going to really help move the needle so that we have all these individuals identified. And again, it will require, yes, we will still need individuals who are identified with cancer. They may not have been had genetic testing. These type of screening programs will then help identify them. So again, one approach of many that will still be necessary. I do want to acknowledge, of course, this is a huge team, wonderful collaborators. Basically, we're creating a whole new network for this. And thank you very much. And I see Nani K, you're back.
I am. Thank you,
Hopefully
Alanna.
I'm right on time.
You did very well. Thank you so much for sharing your team's work. It's very impressive. I want to remind everyone to use the Q&A button at the bottom of your screen to submit questions. You can also look at what questions have been submitted and hit the thumbs up if you want to upvote those. So Alanna, we'll start with what I think might be an easier question. Someone's just curious about the group that's participating in Texas. Who or where are they?
That is probably one of our Catholic Health Initiative sites. So Catholic Health Initiative has different sites, analytic units, clinics all over the place. So a very different model from our healthcare systems in the HCSRN, like our Kaisers and our Geisingers.
Thank you. So one of the main goals of Cancer Moonshot is to accelerate our research and what we know. And a big component of that, and we've talked a lot about it in the Hereditary Cancer Syndrome group, is sustainability of this work going forward. And so, and this goes into one of the comments was talking about you're disseminating the toolkits. What does that look like for sustainability and testing? You know, who's using it, who doesn't, what's the follow-up, what's the success? So if you could speak to that, we'd appreciate that.
Yeah, so, and I want to make, I'm not sure. So first I want to speak to the toolkit itself was designed from the beginning with the idea that we don't want to just implement these programs. We want to make sure these programs are sustained and frankly, evaluated and optimized over time. So the toolkit itself is designed to promote sustained programs. And in fact, we hope, or our intent is for also evolution of these programs over time as necessary and as things change in this space. I'm not sure that that's what you asked. You may have been asking, what about sustainability of the toolkit itself? And so again, we also do plan that. So we are disseminating it through the Lynch Syndrome Screening Network through that website. That's part of the reason we've done the sprints program with our stakeholder engagement, is to see what else do we need to do? How can we better ensure the use of this toolkit over time? How can we get it into the hands of those who want to use this information and can use these toolkits to make sure that their programs, that their sites are optimized or changed and growing and sustained over time, or implemented where they may not have one.
So you'll be tracking who is trying to use the toolkit and the success of that. Is that correct?
We hope to, yes. That may require more funding, but we at least have, on the Lynch Syndrome Screening Network, we are able to see, we can run analytics and that, but, of course, we would want to do way more rigorous evaluation and work towards getting those done and getting the toolkit in the hands of others.
Have you had the opportunity to compare or cross-evaluate your toolkit with other less fragmented systems, such as those we see in the European or Canadian models?
Not yet, no, but that would be a lovely thing we would love to do.
Great. So someone noted that, we can identify these patients who have a syndrome, but then there's the downstream care requirements and costs to the patients for doing follow-up colonoscopies or whatever the recommendations. And there seems to be a large barrier around insurance coverage, out-of-pocket costs to do that. And so is there any work within this that really can address how we overcome that barrier of you've been identified, but we can't really reduce cancer incidence and risk and death if we don't continue to do the screening that's recommended? So really talking about that cost component.
Oh, absolutely. And that's one of the biggest things about, when I get up on my soapbox for the implementation science lens, is it's not just implementing these programs. There's, that's step one. And that's what we did with this project. And we acknowledge that this project is step one. The biggest piece to seeing the change in health outcomes is getting these individuals the care over time. And so we are hoping, again, we've created this network of individuals. They're a huge team within the Impulse project. So we have people within our healthcare systems who are interested in just those things. So we're hoping to do additional projects where we can follow on and start looking at in our healthcare systems, can we improve that follow-up, increase adherence, change, what do we need to change policies? What data do we need to provide for that? Because now we have these healthcare systems, the healthcare system screening, the HCSRN, the Healthcare System Research Network is, that's what we do. We've done for many years, is analyze that type of data. So we're hoping to move forward with that as well.
Great. And of course, that leads to cascade testing, reach out to those family members and
of course,
overcoming those intense barriers, not around only cost, but licensure of our genetic counselors. And so there's so much work it seems to be, needs to be done downstream.
And I will say, anecdotally, that's one of the things, when we talk about the need for these tumor screening programs that catch them, are screening our individuals with colorectal and endometrial cancer. Anecdotally, we've seen individuals who, instead of cascade testing, they know they have they get a family member who's diagnosed with Lynch syndrome. So they come in and get a colonoscopy. They don't go for genetic testing first. They come in and they get a colonoscopy. A tumor screening program for Lynch syndrome will then pick them up. And we've seen that where all of a sudden our tumor screening program, we get somebody who's screened positive, they get to our genetic counselor, and the genetic counselor, when they get to the genetic counseling session, they say, oh yeah, my uncle or my father was diagnosed with Lynch syndrome. And they hadn't done the cascade testing. They came in for the colonoscopy. So that's one of the arguments that we make in our commentary about that, is that's why these programs, it's going to take multiple programs.
Yeah, capture all the different pathways, right?
Capture the individuals.
Right. Question, does the cost model that you provided serve as a model for other hereditary cancers outside of Lynch?
Great question. So I'm going to try to answer it. I am not a health economist. That's why I have my amazing health economics team. But my understanding as a non-health economist of that is that because of the way these models work and the data that goes into the models, they have to create a model for every single scenario, essentially. So the short answer, I think, is no, unless they create another one. So we have a supplement right now where they are, our team is doing the same for endometrial cancer, because we have to do a separate endometrial cancer model. And then we can put the two together, the colorectal and the endometrial together, and give you an overall colorectal and endometrial cancer model. But then they have to do, if you want to do one for breast cancer or ovarian cancer, you would have to make additional models. Now, one of the pieces of the model is, one of the protocols is direct to germline sequencing. So theoretically, in my understanding, my health economist might tell me this would not be precise, but theoretically, you could play with the tool to put in your number of cancer patients instead of just colorectal cancer patients, and use it to get a rough estimate of the cost of a program if you did germline sequencing of everybody. But it would not be precise because the model is set for costs for colorectal cancer screening and identification of Lynch syndrome patients.
So this might be an opportunity to work with others that were funded under this Moonshot initiative that are working in HBOC, Leaf-Romani, others.
Exactly.
See if there's data available that could test the models.
Yes.
Okay. How do you educate and create awareness about this screening requirement? Is that also part of this project, or is that done in another avenue?
So part of the, yes, so included in the toolkit is we have information that it's actually already existing there on the toolkit that's been existing on the Lynch Syndrome Screening Network website, that talks about the evidence for universal tumor screening. Within the toolkit we're creating out of this project is a little more directed of here's some of the things that you can say, or some of the evidence that you might want to present. But beyond that, we haven't tested any implementation strategies around what type of education process works best or anything like that for getting people to know about these programs. I think that's what the question was asking.
But I think within LSSN, the Lynch screening the network, there's a large educational component there that's trying to continue to promote awareness. So I think that's in parallel with what you're trying to do, and the incorporation of your tools into that site hopefully increases education and awareness.
Yes, and that's exactly, and that's the other reason why we've done this engagement activity through the PCORI funds as well, is to understand sort of what is that information that we really want to make sure, how do we want to communicate it, how do we need to frame it, how can we, do we better need to highlight it on the website to get it out there to the people who need it and want to use it.
Are there plans to collect nationally representative data across the healthcare implementation sites such that a data source could be used by Healthy People 2030 to track progress?
Ooh, great question. So theoretically, the HCSRN, we could do that. There are also other networks that would have the ability to do that. We've got people within our group that are exploring other ways to look at that data. So we are exploring opportunities for that.
Great. Let's talk about kind of patient perspective. Is there any conflict for patients with a predisposition to Lynch syndrome to get testing for genomic profiling?
I'm not sure I understand that question. Can you say that again?
I'm not sure if the person who submitted could provide any extra context to it.
They won't be able to speak, but they could.
Well, I was just telling
can you just read it again then?
Is there any conflict for patients with a predisposition to Lynch syndrome to get tested for genomic profiling?
Interesting.
Is there coverage? Was a clarification, I guess.
Is there coverage
for genomic profiling if you have a predisposition for Lynch syndrome?
I'm still, the only way I know how to answer that, and I'm not sure if it's an answer to the question or not, would be, I think it would depend on your insurance and your insurance coverage. Most insurance coverage will cover you if you screen. So if you go through a universal tumor screening program, and so you have colorectal or endometrial cancer, if they follow NCCN guidelines or any other guidelines like that, they will cover the testing for the genetic testing for Lynch syndrome. If you're identified through a program, through a tumor screening program, or you're identified through a ad hoc program where your provider has referred you to genetics because of a family history of colorectal cancer or consistent with Lynch syndrome. If you meet criteria, they will cover the genetic testing. I'm not sure if that completely answers the question.
Oh, thank you. How do you see direct to germline approach for Lynch syndrome screening fitting in with the MSI, MMR biomarker testing for immunotherapy treatment decision-making
Yes.
as we look into the future?
So this is something we uncovered in all of this work, and what we want to do with the next, Impulse 2.0, because we are in year 5 of this project. So you hit that on the head, is we're trying to figure out how do we facilitate that, because again, from a genetic standpoint, our goal is to identify everybody with Lynch syndrome. And so direct to germline sequencing will certainly do that, but you still have to have the tumor profiling. You have to know the mismatch repair status for immunotherapy and things like that. So we've been playing with, we've had people ask us about what does that mean for the costs, and it depends on how your system is set up. And one could be used as a opportunity to implement the other, because if you're doing tumor sequencing, that's already giving you microsatellite instability status for immunotherapy, and you have a genetics program, that can be your facilitator to implement tumor screening, right? Because you already know it, so you can work with your oncologist to then refer those individuals who have microsatellite instability for your genetic testing for Lynch syndrome. So it depends on your program and how you're set up and whether you've got anything implemented or not. And that is one of the things we want to do next too, is see how do we help people do that.
So to be continued.
Yes.
Oh,
But it's a great question. Yeah, that's like that's been one of the big things we realized. And like you have to think about both those things.
so
Thank you so much for your
yeah.
time today, Alanna. Really appreciate it. And thank you to Alan's team for coordinating today. I'll turn it over to Alan for any closing remarks.
Yes, thank you as well, Nani K, for your excellent moderation. That was a great discussion, 20 minutes of questions. So obviously a lot of interest in the topic. So with that, I'd like to remind everyone that our next Moonshot Seminar Series is on March 24th, and there'll be a presentation from 2 NCI program officers, Drs. Gilbert and Armstrong, to talk about the NCI Connect network, fostering patient advocacy provider partnerships to advance the understanding of rare central nervous system cancers. So thanks, everyone. Look forward to seeing you at the next Moonshot Seminar.
U.S. Department of Health and Human Services, National Institutes of Health, National Cancer Institute, cancer.gov, 1-800-4-CANCER.